again, so I have a disclaimer before I present anything on this topic, is that data for use of convalescent plasma in adults is yet not clear. There are data and there are RCTs which are coming who still haven't shown any conclusive evidence of efficiency. Yes, the safety profile have been largely established by various articles, but the efficiency is something which are still being studied. So conclusively commenting on application of CCP in pediatric is not appropriate at this time of the pandemic. So we don't claim that this is the drug of the choice or this is the treatment of the choice. But yes, we have some short experience of 1 or 2 patients where we have used and we have found it to be useful. So in my presentation, I will be discussing what the world is doing, what we have done, and what we have data from India. Though the data in pediatrics is very less, but what does it say? So I have outlined my presentation as I'll be discussing COVID and pediatrics. What are the treatment options available in pediatrics? Then what is the concept of passive immunization, from where we derive this convalescent plasma? And what is the experience of pediatrics in across the world, pan India, and then our center? And as well as what does US FDA say of use of convalescent plasma, mainly focusing on pediatrics, and what finally is the Indian scenario? So COVID and pediatrics, we have since morning discussed a lot how this pandemic has affected our lives, our personal work, our profession, our hospital, everything, every possible thing that we do in a whole day has been affected by this pandemic. And pediatrics, newborns, children, they are not spared from this, though the data is less. So in United States, last week's data says that 33 lakh total COVID-19 cases were reported in children, which represent roughly 13.3 positive cases across the country. So the rate of positivity in children is somewhere around 4,440 on 1 lakh children. So this is a pretty high percentage. Children made up of 6 to 18% of total tests that have been done in United States, and their positivity ranges from 5.3 to 31.2% of all the positive samples that are tested in various states of the country. So if we see hospitalization and mortality, so children were hospitalized and their hospitalization was less. So children were 1.3 to 3.1 of total reported hospitalization, and which was 0.1 to 2.1 of all total COVID positive children. So this is very less. Children were 0 to 0.19% of total COVID death reported from all the states in the United States, and 10 states did not reported any death. In the United States, the reporting of all COVID cases death ranged from till now was from 0% to 0.03. So if we come back to our country is doing a fair job in managing the pandemic, and I feel the ICMR and a lot of national bodies have really come up to the occasion and performed. So we have a data which ICMR and the Health Ministry reports. So till last week we had till before this second peak, we had around 11.7 million confirmed cases of COVID, and out of them 11.2 have completely recovered. We reported around 1,60,000 deaths, and out of them out of the total 11.7 million confirmed cases, 8% were less than 17 years old. And the mortality which was reported in pediatrics was less than 1%, which was around 0.7%. So if we just see a graph of less than 20 years, is pretty less. It's around 10 to 11%. Now, there is a confusion in reporting in pediatrics that some center consider less than 18 as pediatrics, some center report less than 16, and even some center report less than 12 as pediatrics. So conclusively coming out as a pediatric data, the data we need to look at very carefully at how pediatrics has been defined in their data. So this was a very elaborate study which came out recently in Indian Journal of Pediatrics, where a hospital in Bombay who reported admission of 969 children from March to August, where they had nearly 123 COVID positive. So this was the total children that were admitted to their hospital, and 123 were COVID positive. It was majorly 32% of them got admitted in intensive care, and around 11%, that is 12 out of 123, died. So they concluded that COVID-19 in children with comorbidity can cause a severe disease. So this is important that in children, there needs to be a comorbidity for them to get more sick. An association of mortality with oxygen saturation of less than 94% on admission and hospital stay of 10 days was significant in their study, and they recommend that it needs to be further evaluated. Coming to factors which affect COVID in pediatrics. So there have been a lot of hypotheses that why COVID is not that severe as it is in elderly or is it in adult age, as the children are at lesser risk of exposure. So they don't go out to work, they don't work in a high risk area, and because of the lockdown, all the places which may crowd children, such as playing parks, schools, and the study areas were closed. They have a stronger innate immune system. So they have a high level of IgA, which gives them a higher innate immune response in their mucosal surface. So that probably may be the reason why the virus is not that effective when they infect. So they have a healthier blood vessel endothelium. They have excellent alveolar epithelium regeneration capacity, and they have lesser chances of having a comorbidity. So that is the reason why it has been hypothesized that pediatrics and neonates are at a lesser risk. The community spread of virus by children is a concern of high rate because they tend to be more asymptomatic. But the recent data from the United States have shown that there is a slower transmission rate by children than adults. So this is something which I think in coming days or coming months will get cleared up, as there is a lot of work which is being done in this topic. So the clinical course of COVID in pediatrics, so they're mostly asymptomatic and less than 2.5% are symptomatic. And severe and critical cases are seen more in infants and toddlers, and they're majorly with some other comorbidity. So the most common presentation in pediatrics has been cough, pharyngeal edema, and fever, and there have been even the atypical findings of diarrhea, fatigue, vomiting, and nasal congestion. So what are the high risk when we talk about this pediatric patient? So obesity has shown to be one of the significant associations with the pediatric patient admitting with COVID and needing a mechanical ventilator. Apart from that, chronic kidney disease, congenital heart disease, respiratory issues such as bronchial pulmonary hyperplasia, respiratory tract anomaly, abnormal hemoglobin level, severe malnutrition, and immunodeficient state. So these have been are the conditions where if a child is having these conditions and gets infected with COVID, there is a higher chance that the disease may be severe. So what are the treatment options that are available? So not much exclusive work has been done in pediatrics. It has mainly adapted from the way people manage the adult patient. So if we see general supportive care include oxygen support, that is the respiratory support if the oxygen concentration is going low, fluid electrolyte support, empiric antibiotics, which is started in these patients. You keep monitoring for cytokines and vitals just to keep a watch that is the patient going into a cytokine release syndrome. Then provision of thromboprophylaxis, that is if the disease aggravates, then there is a need to provide a thromboprophylaxis. Apart from that, some options which are available to treat these patients are antiviral and some adjuvant options. So if we go to antiviral, so using an antiviral in a pediatric group of patients is a very, very tricky situation. So this has been used case to case basis, based on severity, based on clinical trajectory of that patient, and is there a presence of any underlying condition. So we all know remdesivir hit the headlines everywhere as convalescent plasma, and everybody wanted remdesivir, and there was a shortage, and arranging this drug in a hospital was a big task. So remdesivir was indicated for adults and children above 12 years of age or weight more than 40 kg. Whereas FDA did came out with an emergency use authorization for children weighing more than 3.5 kilograms and weighing age of less than 12 years. So this was just emergency authorization, not an exclusive drug of use. But many clinical trials for use of remdesivir and other antiviral drugs are still going on in the world, where we expect to have some data that whether these antiviral drugs may be used or are they an option to be used in. Other individualized adjuvant therapy were glucocorticoids, which we all know was used in adults very commonly, and this was in pediatrics used for case-to-case basis depending on the severity. There are trials in pediatrics for use of glucocorticoid which is going on, and the benefits is uncertain. Other medicines which were adapted from adult and which were, being considered case to case basis were tolizumab, which is IL-6 inhibitor, which is the most common cytokine which gets released in a COVID patient who's going into a cytokine release syndrome. Apart from that, interferon beta 1b was considered, and then came the passive immunity, which harbor the main and the topic of my day as the convalescent plasma. So this was the treatment options which are available. So coming to convalescent plasma or passive immunization. So passive immunization basically means a concept of artificially acquiring a passive immunity. So this was started way back early in 20th century, where this was initially used for bacterial infections, and then the antibiotics took over. It is still applied for new viral infection, but where we don't have a specific treatment. So this is probably the first treatment modality which is available for a new pandemic, be it Ebola, be it SARS, be it COVID, be maybe the next one which comes in. So convalescent plasma will always be there as one of the options which can be easily provided to these patients. So mode of delivery of this passive immunity is use of convalescent blood products. So as I go ahead, we can't move further without giving respect to this gentleman. He was a bacteriologist in Germany who was given a Nobel Prize for initiating this therapy. He was von Behring, who started or who applied this therapy to treat diphtheria, and he was awarded Nobel Prize for the same. Then over the years in 1920 and 40, this convalescent blood products therapy were used for prophylaxis and treatment of scarlet fever, even pertussis in 1970s. Last pandemic, Spanish flu also saw the use of convalescent plasma as a potential therapy. In fact, there was a meta-analysis which was done on 8 studies and a 1700 patient in Spanish flu, which did show some significant effect of use of convalescent plasma in Spanish flu. So coming an overall umbrella of convalescent blood products. So whole blood plasma from a patient who survived from a previous infection and developed an humoral immunity against a pathogen responsible for the disease. So this is, we take any whole blood or just plasma that can be used to treat other patients. So possible source is that we collect humoral immunity or antibodies from the person who is recovered. So there are different heads of convalescent blood products. So you can use a whole blood, you can use plasma or serum, you can use pooled human immunoglobulins for IV or IM use. You can just use a high titer immunoglobulin, which is exclusively being studied even in COVID. And then there is polyclonal and monoclonal antibodies which can be used. So all this comes under an umbrella of convalescent blood products. So why should we consider CCP in COVID-19? So we do not have available treatment of choice. There is yet no drug. We have seen recently, as the first wave ended, ivermectin oral dose have shown a good result, and it has shown to be effective in treating milder cases. But yet we don't have a drug of choice at present. Possible clinical efficiency. So this is yet being evaluated in COVID, but in some of the previous pandemics, the convalescent plasma have shown to be clinically effective. Immediate availability from large pool of donors. So this we know that when a pandemic strikes, you have a large pool of people who are eligible once they recover that they can donate. So you have this therapy which can be readily available at a lot of places where maybe a new drug or a new therapy reaches. So before that, this is an easily available therapy. Safe for transfusion and safety profile. Now, even in COVID, the safety profile of CCP has been largely established, and the same has been established in the other pandemics as well. So this is largely safe to be initiated and used. Relatively ease of procuring. So you don't have to put up a big machinery or a big factory to get to start producing this drug or this medicine. So you can easily remodify or restructure your blood bank services, as every country and as our country also did. And then there is relative ease of procuring. Cost advantage, as this is not very expensive as compared to some of the antiviral drugs, and they may also have some role in prophylaxis. So this is a good area which people are working on, that can the high titer convalescent plasma or high titer immunoglobulins, can they be injected to the healthcare workers, especially working in the isolation area or the COVID ICUs. So what is the mechanism of action? So in a very specific and a short manner, that we collect a high titer specific antibodies which are able to bind the COVID virus and neutralize the viral particle. It blocks the access to an uninfected cells. It activates potent effector mechanism, which is majorly through the complement activation and phagocytosis, and it can be administered early enough. So it should be administered early enough. So this is what has, in short, come out, that we collect high titer plasma and we give as early as possible for it to act. This was a very early data, or a very early review, which was published in May 2020, where a group of people from China, where the pandemic started, they showed that they have found that CCP can be a good therapy which can be used for treating a patient in COVID pandemic. Coming from past experience, so this was an article in NEGM where for Ebola they studied it on 84 patients, and they found that it actually did not show much of an effect in improving the survival of Ebola patients. So we had some mixed experience coming out. Now, this is a very recent paper which is published in JAMA, which actually collaborates all the good RCTs published across the world on CCP in COVID. So they took 10 RCTs, and out of them 4 were peer reviewed, which consisted the ICMR Placid trial, which had total around 1060 patients, and there were 6 which were available on public domain but were not peer reviewed. So this had total around 10,000 patients. So a total of both they analyzed, and they saw that treatment with convalescent plasma compared with placebo or standard of care was not significantly associated with decrease in all-cause mortality or even with any benefit in clinical outcome. So this was, I mean, from a transfusion medicine point of view, was a pretty disappointing outcome, but we still are looking ahead at a lot of other studies which have been published. But something which I wanted to highlight in this paper was there were some limitations that they cited, were 3 out of 10 RCTs which they analyzed were only looking at a very high risk group of patients. So they were looking at moderate to sick patients. So your data is kind of skewed towards a sicker patient, and then there is no specific criteria from the day of starting of your illness, that when did you initiated the CCP treatment. So were you late, were you early, were you in time to provide this therapy? The other thing was reporting of clinical outcome data was insufficient and inconsistent for user definition. So how did you define clinical outcome? How did you define improvement in the therapy? And how did you define even deterioration of clinical outcomes? So this was not constant in all the papers. The data was too limited to perform subgroup analysis. So we do not have enough patients to do a subgroup analysis, or maybe people getting infected above 60 years or less than 45 years, or maybe with a history of diabetes and hypertension. So maybe they are not the people who may improve better with CCP, or maybe they are the group of people who may improve with CCP. So this subgroup analysis is not done. So except one RCT, which actually talked about outpatient patients receiving CCP, all the patients were hospitalized and with and without oxygenation. So this was indicator of sicker and critical patients that they read. And then finally, the primary focus of this meta-analysis was on published RCTs. So there are more than 100 which are still going on across the world. And I think, as Dr. Vijay, explained in his previous talk, that this is something which is going on. This is something which the data will keep on coming in. Every day we have a new article, new information which comes in. And I think the clarity on CCP use and COVID will definitely give us more clearer picture in coming days. So coming to PEDS, that is something which I want to talk about. This is the largest published paper, largest experience published for PEDS use of CCP, which was done in Poland. So this is also a very recent one where they used CCP to treat 13 pediatric patients. So their mean age was 10.4 with median of 12. So this is the list of patients, and the youngest one was 5-month old. So you can see that all these patients have some or the other comorbidity where, the use of CCP or the disease condition of COVID was expected to deteriorate, and the patients were expected to, been maybe not managed easily through.
Satyam, I think you have unmuted yourself. We are not able to hear you.
I am unmute, sir.
Now you are audible.
Continue, sir.
Okay.
Now you are audible.
So they concluded that the clinical improvement was effective in all these. All the patients improved, no adverse effects, and now coming to some sporadic case reports which also came out in pediatrics. So this was a 6-year-old girl with aplastic anemia was used where and another one was a pediatric patient after hematopoietic stem cell transplant. So this was a 9-month-old girl with juvenile myelomonocytic leukemia, actually received a transplant from a haploidentical donor. Till day 99, she was okay when she was found to be positive with COVID, and then gradually how she was treated by use of convalescent plasma, and then they demonstrate that there was an atypical course of COVID in this case, and the patient did improve. Now this was another case report from India. So this was reported from girl was reported to be presenting with the mild to moderate to severe COVID, where she was offered convalescent plasma therapy and she was successfully treated out of it. Now, this is our institute's data, and this is something which is published. So I will be discussing only the part which has been published, as many of the data is still under peer review. So our institute admitted exclusively 131 patients with COVID in pediatrics. Out of them, 15 were moderate to 6. So they were less than, they were around 1%, 1.2%. And this is the data of the pediatric patients. So you can see that most of them had some or the other underlying condition or comorbidity, and they presented, and few of them did presented with mild to moderate, and 2 of them went to be severe. So one was an acute aplastic patient and acute lymphoblastic leukemia patient. Another one was sepsis with meningitis. So both these patients were offered convalescent plasma, and they both recovered. So this is a very small data, but it's a very significant data from India, from world. There is very less data which is being published from pediatric point of view. So fortunately, both of these cases were published during the COVID time, and this was the first case where 4-year-old girl who reported with who associated with pneumonia, present with febrile neutropenia, and then she was suffering from ALL, and then she was offered this CCP therapy, and her fever from even after the first dose and then the second dose, her fever dropped down, and and oxygen requirement also dropped down. So upon CCP, the other treatments which were offered were steroids, IVIG, azithromycin, and even the other cocktail of drugs, antifungal and antibiotics. So we still can't say that CCP was the main drug which helped, but definitely we have seen that even after giving more dose of CCP, the patient improved. This probably till now is the youngest patient to receive convalescent plasma as the published data. I'm sure there'll be many patients. So this was a 58-year-old female who reported with fever, difficulty in breathing, loose stools, vomiting, and refusal to feed. Laboratory workup showed anemia and leukocytosis with elevated neutrophil counts and thrombocytopenia, and her culture was positive for a gram-negative bacilli. Along with the antibiotics, she was also offered a 50 ml of convalescent plasma. She was off oxygen within 2 days. She showed improvement in lung lesions, and she was RT-PCR negative on 7th day and discharged on 10th day. Something unique that we were able to do in this case was we were able to screen that the patient had not developed any antibodies to this disease. So this was something which came out by the ICMR guidance document as well, that before administering the CCP therapy, we should screen that patient that they have not yet established their own immune response. And then the plasma which we gave, for that we also had the data on the neutralizing antibodies. Somehow, luckily for this child, this was an aliquot from the ICMR Placid trial units. So we had the data on the neutralization assay titers as well. So this was somewhere where we had more data conclusively, at least on the CCP therapy side, to say that we have given enough and a good amount of antibodies to this patient. So what does the world say? So this was a paper which actually came out 2 days back, 25th March. So I was happy to have it with me. So this was published in Blood, where they have done a very good analysis, and this was done by Dr. Erica Woods, who presently is the ISBT chairperson. And she came out with this paper where they say that optimal product characterization. Now, this is very important, which even the ICMR and a lot of other group of people have also said that, including we need to characterize what product that we are giving. Is it having appropriate amount of antibodies? How have we analyzed these antibodies? Is it been on ELISA? Is it been on chemi? These antibodies are against which antigen that we have tested? Is it against N antigen? Is it against spike proteins? Or the classical or the main one is the neutralizing antibodies? Then what is the transfusion volume? Are we giving less? Are we giving more? Or giving just within two doses in a span of 24 hours is optimal? Should we do, or should we do it in more than 24 hours? Then administration timing still remains to be determined. So this is something which is coming up. Preliminary data on CCP have shown that it is safe and it is encouraging to use, but clinical efficiency is something which still needs to be evaluated. So she came up that finally results from trial in adult population may not be generalized in pediatric patients. So this is something why we need to have more pediatric data. In fact, my center did put up a proposal to DCGI initially that we should do a clinical trial for a pediatric CCP use, but our project was denied, considering that we won't have enough patients in pediatric of sick category to have some statistically significant number. So this is definitely somewhere, this is probably an area where we don't have enough sicker patient in India or in most of the parts of the world to actually do these studies in time. Although SARS-CoV-2 generally appears to be milder disease in children, but some do develop severe disease, including those with comorbidities and immunosuppression. As we have seen comorbidities in our 58-year-old child who had sepsis, and in immunosuppression in a post-transplant or an ALL patient. And they may benefit with the CCPU. So this is something which is still being analyzed and is evolving. Now coming to what does US FDA say? We all want to look at before we plan anything in probably any part of the world. So this was the last recommendation which FDA updated on 11th of Feb. So they say that CCP can be used in 3 ways in US. One is an emergency use authorization where you don't need to report to FDA, you use it case-to-case basis. The other one is a clinical trial mode where you put up a trial, get an approval, and then enroll patients. And then there is an expanded access. So this was something which was talked about a lot in India as well, that expanded access is a very good option where you have sicker patients, you have patients who are deteriorating fast, who have immediate life-threatening options and life-threatening conditions, and they are not eligible for any trial to be enrolled. So in Placid trial, they had a very strict criteria of going into moderate disease. But what happens to people who go into severe disease? So this is something which was opened by FDA. And in their guideline, they did say that patient of less than 18-year-old with convalescent plasma should be used on case-to-case or individual basis. Coming to final, the Indian scenario. So CDSC and ICMR, they did came out with a lot of guidance and notifications at time to time. And the last and the final guidance was based on Placid trial results that they would want to use plasma majorly under a trial option. Off-label can be used, but you need to define that you have a high titer plasma, you transfuse them as early as possible, and your patient, the recipient, should be antibody IgG negative. Finally, there are more questions that we probably come up instead of answering them through this CCP talk. That what is the timing, what is the dose, how many days from clinical resolution should we collect the plasma to have correct or the optimum amount of neutralizing antibody? Is clinical therapeutic effect related to antibody titer? So is it something more or is it something else that we give to the patient and it improves? Effects in children, neonates, and pregnant females. So this is also a very important group which needs to be, we need to have some data on this. Now, role of ABO antibodies. So we have seen that ABO antibodies have played a role in severity of the disease. There have been many papers on this topic where we have seen that O and B are relatively better placed because of anti-A antibodies. So does these antibody play a role both in the donor and in the recipient? And this is something which I think with the subgroup analysis may come out in coming days. Pathogen inactivation is also a very important topic. There's been 1 or 2 publications till now on use of pathogen inactivation in CCP, but we still need to have more data. Then which is better? Hyperimmune serum, you give a shot of 3 ml, 2 ml, 5 ml concentrated antibodies, or CCP, which one is better? Is the antibody alone working, or there is some other cocktail that we are giving in the patient that helps them? Finally, I just want to conclude with this Aristotle saying that be a free thinker. Don't accept anything that you hear as true. I think this is very important in the middle of the pandemic as data keeps on changing everywhere. And we have a lot of huge WhatsApp library, which keeps feeding us as well as a lot of people. Be critical and evaluate what you believe in. So I again want to, say that keep reading, keep searching on the web. This era with the internet and the web is a boon to this pandemic where we can spread out the information, we can read, and please trust only on peer review articles. Don't go on preprints unless they are accepted. Thank you again.